Dr. Deepti Mishra. I welcome her to present the next talk. She is a senior consultant in the Department of Surgical Oncology at the Hospital. She has completed breast oncology fellowship from TMH Hospital, Mumbai, colorectal fellowship from South Korea, and peritoneal surface fellowship from Singapore. Over to you, madam.
You can see here I have combined two talks together, reason being that we surgical oncologists, we don't want to be in between the plastic surgeons and lymphedema. So just more focus on you, less focus on us, although we are the creators. So anything we discuss, the thing is when we discuss about any topic, we take the reference from other countries. As usual, India is lacking in the database, whether it is the stats for the cancer or for the side effects. So in a global prospect, we should not just focus on when we are talking about the lymphedema only when we create for the cancer. So just we all know, I'm not going to the definition and all, but good thing and bad thing is that people have realized in both in the medical and paramedical fraternity that it is a complex and common and chronic problem. But still people are not appreciating from the medical fraternity how big is the problem. In last decade, if you see, the number of centers which are doing surgeries related to the lymphedema or the giving treatment with the lymphedema have increased. That's a good sign. I am not going in detail. We all know that lymphedema can be divided into two parts, like primary and secondary. Primary is totally different and the management is again very complex for that. Secondary lymphedema we see in day-to-day practice. It can be especially with the oncology related dissection and most common things which even in general surgery practice also we see breast surgery, breast cancer surgery. Then related to all gynecological cancer, whether it is ovarian, cervix or endometrial cancer. Others like prostate, melanoma, all the things. Apart from that, there are certain chronic conditions like repeated injury, arthritis, some infective etiology. Those all can give rise to secondary lymphedema. So our main concern here is to deal with this secondary lymphedema. So this very good article I found, I was searching for something like Indian Lymphedema Society, lymphedema management in India. So I could not get it that one society is there, if up to my knowledge. I don't know whether it is existing or not, but I could find Sakara Hospital in Bangalore, it's coming second. I could find some lymphedema unit, but no individual, no, there is no society per se. But if you see, there is a concept of Lymprint study. It was started multiple countries. They have just combined it and on the one basis to assess the impact, to give a common definition. Because now not only the lymphedema, there are certain conditions which cause chronic edema. So it can be because of vascular causes, it can be because of other reasons, but the treatment may be probably the similar. So they have given it's a very good collaboration of group to go through with. So burden. Now coming to the Indian problem. We all know whoever has worked in the northern part of or eastern part of India like Orissa, Madhya Pradesh, UP, if you see, this is a very common feature. In your neighborhood also you would have seen the people suffering from the filariasis. So you know that we have 40% of the filariasis induced lymphedema burden is from India, and it's a huge number when we are so many in the number. And government has declared it as a physical disabilities. So it means that we are recognizing it's a long-standing problem, and our target, India and government has kept the target of eradicating filariasis by 2030. And these are huge and difficult to treat problems. So I'm coming again to the now more common thing which we are dealing with is the burden. It's not Indian data again, it's a range of what I have quoted here. So the most commonly we know that breast cancer, because again it's the most common cancer among worldwide in the women. So when we do axillary lymph node dissection, when we take out the lymph nodes, it is very high rate of 24 to even 30%. It's an average I have put here. Now we have tapered our surgery to the sentinel lymph node biopsy, but that also cannot avoid lymphedema completely. Second comes the gynecological cancer when we do lymph node dissection, because when we talk to somebody, when somebody has operated and patient comes to us, we always boast to tell we are oncosurgeon. they would have not removed the lymph nodes, we remove the lymph nodes, like that. But we just forget here that what we are creating, it's not that we are doing wrong, but this is the thing which we have to keep in mind, how to reduce this problem. So we see lot many patients treated with the surgery along with radiation and suffering with a different type of edema. It's not only lower limb edema, it's abdominal wall edema, which we get many a times when the patients are coming with the radiation and surgery both. Then the melanoma, colorectal, head neck also, we are the capital of head neck cancer in the world. We know that there is, when the things are combined, suppose somebody has undergone the neck dissection and the radiation he or she has received, we know the burden of lymphedema is huge. And the head neck is the site, I don't think so much, many centers are doing something for those lymphedema. So just in brief, we know risk factors are when there is lymph nodal burden is high, when we are expecting there is multimodality treatment like surgery, radiation, chemotherapy. Obesity is another thing, because we also see in our day-to-day practice that you have done the same surgery in the different individual, the outcome and the side effects are different for everybody. So there are multiple risk factors for that. And lack of prevention measures. We do not think about the thing, how we can prevent it. So these are the risk factors. We don't have that foresight, okay, how to prevent this, and we just do the treatment. Then the prevention. So again, we are just cutting shorts the treatment now, going to the radical lymph node dissection. We are just switching to almost all the cancer. It is the endometrial cancer, melanoma, skin or breast cancer. We are all moving towards the sentinel lymph node biopsy. And another thing which we always discuss in all the forum, non-oncological forum also, diseases like carcinoma cervix. Still, if you go, the people are doing surgery, they are giving radiation, and the patients come with a huge limb and abdominal wall. So always we have been taught in our institute that try to do single modality treatment for these type of, wherever we can avoid. So these are the prevention criteria. And lymphedema clinic whole day we are going to discuss about that. I don't think so that still there is a concept of making a lymphedema clinic in all the institutes. So I will tell here, clinician is ignorant, yes we are, and patient is happily. When we discuss about the cancer, we tell them we are going to do this surgery, that surgery. One point, some of the patients may get this type of, you may or may not get. So that is the standard thing. I explained them, we will do this surgery, but don't think that you are in 10% or in 20% group that you will get that side effect. So both of everybody is ignorant, and we are playing ignorant happily. So another thing, when I was trying to search, then one criteria, we know that if you see, the everybody is now talking about the quality of life. So there are certain questionnaire which we will get, okay, standard questionnaire. I was searching for that. The lymphedema questionnaire is still not finalized. It's not standardized yet. So it means that we have not started working even on with the huge problem which is lying in front of us. We have not started thinking, and there is no standardization of even QOL. So now coming to the clinician, because here we have to deal with the two factors. We only cannot tell although the topic is impact on the patient, but the impact on clinician is also very high. We know this is a recent ICMR that around 72.5 million patients are living with the cancer in India, and every year 7 or 8 lakhs are adding. If you see that list, the most common lymphedema associated with, those are the main cancer which are now number one, like breast cancer, cervix cancer, the prostate cancer, all those are come in the category of lymphedema. Large number of patients are being treated in the non-oncology unit. So I don't take it in wrong way. In a huge country like India, if you tell that every patient should only be treated by oncologist, then it is not possible to cover the whole India. So I am not against it, but the principles are something different, which in non-oncology units are lacking. That's the thing, that's a discussion I just want to bring. Whoever does the surgery, whoever does the treatment, it should be evidence-based, and it should be always discussed prior. Oncology centers, even when I'll give our example only. When we started something, our focus is to build the surgical oncology unit, medical oncology unit, radiation oncology unit. Okay, after some time, few months, few years, we will develop rehabilitation unit. Nobody focus first on prevention, because prevention will not give the, running in a hospital, there are multiple things. So running the prevention alone will not give anything to any recognition to institute. So what I am thinking, retrograde, we have got established, but it was not the one that in the beginning we thought with the onco it comes the rehabilitation. And many units what I have seen in India, they are so-called oncology centers, but lacking in this type of facilities. Lymphedema clinic, I think so need is huge, but specialists are very less because it's a time consuming, starting from the good dedicated physiotherapist to occupational therapist to a lymphedema surgeon. It's a very time consuming thing, and nobody wants to just give his prime time of profession to doing this tedious job. That's the culture now coming to the medical field also. So when I was making this slide, I was remembering about Sachin sir. He goes and we just send him patients and he counsels. They don't, patient doesn't understand what is the doctor talking, what this microsurgery is, but he's trying to convincing. Then he comes to the management and he tells that this is the cost and that much, and everywhere he gets a no. So he is always thinking it's not he. I am assuming the most of the plastic surgeons who are in the field of dealing with the lymphedema, they are in this position because actually it's a difficult situation. It's not an easy job. Go and do it because it needs a lot of training. It needs a lot of expenses. So mostly the surgeons are plastic surgeons facing this. So again, that everybody has realized from the patient perspective that it has been realized that it is a globally prevalent problem. And if you see in the many countries they're talking, there are many YouTube talks about these things, but still, at least we are at par with the developed countries here because they are also not able to deal it completely. We are also not, although our number is huge. So now coming to the patient-related problem, all these are all of us are knowing just to revise, just to reinforce. I have kept these slides because when we sit on the counseling part of thing, we just forget, we only think about the disease when the functional, somebody is, maximum patients now when it comes in the urban area or even the rural area, ladies are hardworking ladies, they have to use their limb, whether it is lower or upper edema, so it's really impairing their professional and even household work. Because of heaviness of the limb, loss of flexibility, skin-related changes, always the mind is there, whatever is I have many patients who are teachers, even some office workers, always their mind is, how is the arm going? Is it now it is less, it is more, and when I sleep it is more, like that. So it's actually serious impairment for somebody. Social. So whenever even if you see in the current date, every human being is just conscious about how I look, what I wear. I want to wear it. I want to. So in India also, many times we tell them don't put this tight, this thing. But it's just we don't remember how was the quality of life earlier. So this is a very huge problem. They have a huge feeling of stigma, loss of self-confidence, and the disfigurement. This is definitely definitely a problem which has to be dealt with. And psychologically, many things we just counsel and leave, but the day-to-day life, in lack of proper guidance, it starts again from before the treatment starts. Ignorance related to the problem from both the sides, from the clinician and from the patient side. They feel isolated, there is episodes of depression, they need lot of counselings. Economical, this is a huge burden again. Prevention itself, if a patient is coming, you know that we are just in all the places wherever rehabilitation program is, it starts from the beginning. And each sitting, sometimes the patients are in the physiotherapy, then they go for the multiple line of conservative treatment. Everywhere they have to just shell out some money. It's not without that. And when it comes to the surgical management, we all know it is costly. Additionally, India particularly, we see multiples, this all we can see not only oncology and other fraternity, also that in the medical field also related to the chronic infection, people are coming with the cellulitis, chronic edema could not be done. Even we get frustrated, oh again he has come or again she has come, nothing I can do, that's the limb elevation, this does give some fasciotomy. We know that it will not work. And this gives the frustration. This is a very common thing in India. It's not something we have to see. Maybe the surgeon from Japan, she may get thinking, what is this from this word? But Indians, we know that is a very common scenario for us. Another thing is, there is a literature proof that these lymphedema can give rise to non-melanomatous many cancer like squamous cell carcinoma, basal cell carcinoma, because of the chronic injury. So that is another huge problem. So if we talk, when the word lymphedema comes, it's a problem only. So probably we can give some hope at the end of this full CME. So we are sitting at the verge of crisis, look, like any other things. When being an oncologist, when I talk, we just talk about the treatment. We never talk about the prevention. Many focus is, okay, breast cancer, how we'll do conservation surgery, what we'll do. But less of us are going for prevention. Same thing is happening in this field also. So we are at the verge of crisis. We all should remember this. Urgent need is we have to understand the problem, and the solution of problem will start from as the first interaction of the patient. Focus on the prevention. Training of clinician is very important. Awareness among the patients, because recently when we were trying to counsel the patient, they were telling, no, sometime I get, most of the time I'm normal, doctor, why do I need all this? It's a very difficult job to convince them, because they'll give initial phases, they'll give once an episode of the edema, and it is very difficult to tell them that in the future you may get this a huge limb. No, doctor, I'll just do with this stockings, give me some conservative. So it is very difficult job for a clinician to make them understand. And insurance coverage, it is wherever you apply, they don't give. They think that's a cosmetic surgery, and no insurance company is still covering, at least in India, in my knowledge. So these are the problem, and we need to solve it urgently. Some few myths, it's not related here with the new things. If we have come, whenever we used to operate breast cancer and all, always we used to tell them, don't put any IV line, don't put blood pressure, don't do this thing. But actually these myths have been now removed from the books, that these all are not main cause of for the lymphedema. People were telling don't do exercises after the surgery, but all these are actually exercises are helpful to create a flexibility of limbs. So these are the myths which is not related here, but I have put here. So here I am just saying he is our soldier alone. Till now I'll tell him alone. We create, he corrects. He has a long battle to fight. I think so in due course we all will understand, and we have started understanding, and hope this whole day program will be a initiation for that. Thank you all for coming here and who all are attending this program. We welcome you all. Thank you.
Thank you, madam, for the nice talk. You gave a nice overview of the current problem, the challenges that are there, and the role of prevention.